We have to keep in mind that this is a medical disease. It's not a surgical disease. The intent is to remove the polyps and to allow all the medical treatment that is locally administered to get to the right spots.
That shows that ongoing suppression of the type 2 inflammation needs to continue. Biologics are such an advancement that patients don't need prednisone all the time. So I'm hoping one day if we have something better.
Use of biologics has more value when they are used after surgeries in order to prevent recurrences rather than the first line of treatment.
This is the Transformational Life Consulting Podcast with Deepa, Grandon, MD, where Christians like you get the practical support and tools you need to build your spiritual, mental, and physical well-being, and to guide you on your journey to health and wholeness based on evidence-based science and God's Word. I am your host, Dr. Deepa Grandon. Welcome back to another episode of Time to Transform. So to our returning community, it's always a privilege to have you here in this shared space of growth and intentional living. So if you're joining us for the very first time, I want to say special welcome. And just a reminder for everyone, our mission here is very simple. We want to keep our discussions meaningful, and we want to bring insights that are not only thought-provoking, but can be applicable to your life. Because really, at the end of the day, my hope is that we are not building just some medical information out there, but helping people build habits. And by cultivating healthy, intentional habits, we can align our spiritual, mental, and physical well-being. So today, we're actually going to be diving into a condition that is very, very uncomfortable for those who suffer from it. It nearly affects 12% of the global population, and it remains one of the most complex and frustrating challenges, especially in the allergy ENT world. And that's chronic rhinosinusitis with nasal polyps. In short, it's known as CRSWNP, standing for chronic rhinosinusitis with nasal polyps. So for those of you who are not familiar with the term nasal polyps, it's just they're like soft, painless little growths that can happen inside the nose and sinuses. It's more like swollen tissue that can block airflow. So people who struggle with this, it's not just that their nose is blocked, that they cannot smell, and they sometimes have to take steroids. And that feeling of a blocked nose that never goes away no matter what they're doing, it really affects quality of life, like you can imagine. So for decades, the cornerstone of management has been endoscopic sinus surgery, also known as ESS. It is designed to physically remove polyps, to restore sinus drainage, improve access for medical therapy. And yet we know that it comes back. And the recurrence issue is actually a significant problem, especially in patients who have what we call type 2 inflammation. So that's where the allergist plays a role, because for us, we are dealing with type 2 inflammation in pretty much all of our patients. So for what exactly is type 2 inflammation? So your immune system, just the way it responds to different triggers, it makes these chemical messengers, if you will. They're called cytokines. And in the type 2 inflammation, these types of messengers are your interleukin 4, 5, and 13. And this can lead to all kinds of allergy issues. You have the swelling, the mucus production, and you have these cells called eosinophils. And we see this problem, especially in asthmatics. And a good majority of these patients who have polyps also have asthma. So you're talking about as high as 40 to 60%, especially in these high-risk patients, right? But now we have a lot of great tools in our toolkits to help these patients, because it's not just about surgery anymore. We have something known as biologics. It's also called precision medicine, which I'm sure most of you have been hearing more and more of. So we're trying to understand, why is this specific person having polyps over and over again? And thankfully, now we have agents such as dupilumab, omalizumab, mepolizumab, and I know it's a mouthful. And more recently, we had the approval of tezepelumab. which was approved in October 2025. So the great thing about the most recent one, the tezepelumab, while the dupilumab and omalizumab, mepolizumab, we call them more like targeted downstream, where they target these downstream chemicals, meaning it's a whole pathway. So you can think of a river, it has an upstream and a downstream. The tezepelumab actually blocks the effects way upstream, very early. And so we're actually seeing amazing results with this. And so targeting the what we call TSLP, or thymic stromal lymphopoietin, it seems to be affecting the inflammatory pathway in a much broader sense. And so patients who've had to have repeated surgery, it can significantly reduce that. So we're very excited about this new approval and how much benefit we're able to provide our patients. So coming back to the question, surgery versus biologics, right? So we are entering a new paradigm where the approach is no longer, oh, which one's a surgical candidate, which one's a biologic candidate. We're actually working together. It's more of a coordinated, patient-specific strategy. So to help us navigate this really rapidly evolving space, we've brought together two amazing experts who can represent the forefront for their specific discipline. First, joining us from Cleveland Clinic, Abu Dhabi, I'm so grateful to have Dr. Anastasios Hantzakos. I hope I'm not saying that incorrectly. He is a staff physician in otolaryngology, and he's also the residency program director. Dr. Anastasios, he actually brings a very great global perspective. I mean, he's been trained and has clinical expertise across the United States and Europe, and now works in the UAE. So beyond the operating room, he's also an endurance athlete, very impressive, someone who understands firsthand the critical importance of airway function, performance, and resilience. And then we have a beautiful Dr. Deepa Sheth from Washington, D.C. She is a leading expert in allergy and immunology in the Washington, D.C. Veterans Affairs Medical Center. She has a strong academic and clinical background. Dr. Sheth specializes in type 2 inflammatory disease, like most allergists. But the very pathway that drives the CRS with nasal polyps, or the chronic rhinosinusitis with nasal polyps, is your type 2 inflammation. So having her expertise and explaining how some of these biologic works is extremely crucial. So we're truly grateful to both of you for taking the time from your busy schedules to be here and explain to all of us and help us to understand things a little bit better. Dr. Anastasios, we'll start with you. And if you're okay, I'll call you Tassos.
Yes, thank you.
Yeah. So before we start, can you tell us a little bit about yourself? What got you interested in ENT?
So first of all, thank you, Deepa, for having us in this forum. I'm really, happy to be here with you. Thanks for all the good words. So I would say that ENT was not really, I'm not the type of doctor that say, oh, that's what I always wanted to do, right? So during medical school, we get exposed to various different specialties. And along the way, we develop what may be more suitable. And this is actually something that we all share commonly. The decision is never the one that you started med school, sometimes never the one that you finished med school with. So I would say that ENT attracted me because it has a combination of both surgical and clinical practice. And I would say that in the vast majority of otolaryngology and neck surgery, most of us in the clinical practice are doing practice at the office rather than in the operating room, unless we are in an academic setting or in a large tertiary quaternary medical center in which we invest more time in surgery. So I'd like that combination. I like the fact that you can combine clinical practice together with surgical practice. And I think this was the key factor that led me to ENT. And eventually I ended up developing, my certain narrowing down my expertise to certain domains, and that is rhinology and primary laryngology. So these are the two things that I really love most.
Yeah, that's such a cool story. I think all of us can relate to that, because for me now, lifestyle medicine is such a huge part of my practice, and it came because of my own life experiences. And being able to incorporate that into my immunology practice, and Deepa can also relate to
I'm
that.
glad you touched that. So this is what I have here with me.
Oh,
Just,
wow.
with
That's amazing. So, are you lifestyle boarded?
I'm not because I took the exams, but I needed to complete the CMEs, and that was at the
Oh,
time that required physical presence, so I could not really, get my results
sure.
back.
Yeah, yeah.
So I'm willing to do it again because they allowed CMEs to be credited through online sessions.
Oh,
So I'm
good.
gonna one time. So yeah,
Oh,
there it is.
good, good. So I have another lifestyle medicine physician to
That's a pretty much
collaborate with. That's amazing.
there you go.
Yeah. So,
Thank you.
Dr. Schatz, thank you again. And can you also, and I'll call you Deepa because you and
Mhm.
I have been friends for a long time. And can you tell me what drew you to the field of allergy and immunology?
Yeah, absolutely. Thank you very much for having me. I'm very excited to talk with both of you today. Um, for me, I think it's very similar to his story where you just, you love all of medicine, right? It's a hard decision to make. I think for me, I really love preventative medicine and I love initially when I picked allergy, I could see the effect of allergy and asthma in my own family. We have a lot of patients, a lot of people in our family with asthma, but just seeing how it affects you on a daily basis.
Yeah.
But I also wanted to have a relationship with, if I was seeing pediatrics initially in fellowship, before I wanted to have that relationship as an ongoing thing, not just a one-time, you know, visit. I wanted to take care of somebody over time. And so that was really important to me as well. But I also saw that there was so much unknown in allergy and immunology, and I knew it'd be a really exciting field to sort of grow with. So
Mhm.
that was part of it as well. So a kind of combination of things.
Yeah, I think a lot of people with the allergy immunology field, they like that long-term relationship with their patients. I think I've seen that with the rheumatologists as well.
Mhm.
Yeah.
Absolutely.
All right. So, so Tassos, I'll start with you. When we are dealing with patients with chronic rhinosinusitis with nasal polyps, how do you determine when surgery is the right next step versus continuing medical therapy, including biologics?
Right. So, I mean, that's a very good question. It is quite often that we encounter patients that they either select a medical or surgical treatment themselves. So it's up to us to guide us to what is the appropriate way to approach this problem. And that's why there are guidelines that are, have been, posted in the national literature, coming along with studies and multiple studies and reviews that will help us counsel these patients appropriately. So certainly a patient that comes that has exhausted medical treatment, so with the conservative management, such as with using of steroid nasal sprays and the histamines, had already had a thorough workup by allergists and immunologists, to which we incorporate very frequently here at CCAD. So if conservative management has been exhausted and the patient's quality of life, as it that can be determined by questionnaires that are given, is reach to the point that becomes, to the point that he's desperate or she's desperate, then it's when we counsel them for surgery. So we need to have factors and we have to have the agreement of the patient that there's nothing else left but to proceed with surgery. There are some cases, obviously, that having polyps that have been staying for too long inside the sinuses, they may end up getting what we call invasive properties, which means that some of the bony boundaries of the sinuses have already been breached. In such cases, there may be an imminent danger of causing complications from the chronic presence of polyps in the nose and the chronic inflammation. So these are the other decisions that we have to take into account in order to counsel someone to not lose much time with conservative management and move to surgical treatment.
Yeah. And I mean, I've, collaborated with you before, and I know you're very conservative. You've really liked to try the medical route first. And it's really the ones with the bulky nasal polyps that will need all the nasal passages to be opened up and even make the usage of the intranasal corticosteroids beneficial, or else it's like hitting a brick wall, right?
Absolutely. I mean, we have to keep in mind that this is a medical disease. It's not the surgical disease. We know that polyps is a reaction of the tissue, of the lining of the
Right.
sinus. So whatever we surgeons are doing to the point that we would like to help the patient get rid of that burden, of that blockage in the nose, open the sinuses in a functional way. That's why we call it functional endoscopic sinus surgery. So it's not an amputative surgery, it's a functional surgery with the intent to restore patency of the sinuses to allow for the nasal washouts, the steroid sprays, and all the local treatment to enter the sinuses and the sinus wall to prevent the redevelopment of polyps. Now, as you know, this is a very wide gray zone. So if you look at the literature, you may see studies that have been showing a successful rate of these treatments, and studies that have shown significant percentages of redevelopment of polyps. So that's why we need to collaborate very closely to find what would be the optimal treatment for these patients, but also to counsel them that surgery is not the end. They should continue conservative management to slow down reprogression or redevelopment of these polyps.
Yeah, and that's why the personalized medicine, where we're trying to identify root causes, is so important. And I think, to your point about collaborating closely with the allergist, because that's our role, we look at biomarkers, what are the comorbidities? And that way we're able to better determine which path of treatment would work better for these individual patients. So, yeah, that's a great point. And Deepa, we now have 4 FDA approved biologics for chronic rhinosinusitis with nasal polyps: dupilumab, omalizumab, mepolizumab, tezepelumab. So they're all targeting different parts of the inflammatory cascade. And to Tasso's point about personalizing and identifying the root cause, can you explain how each works at the immunologic level and which patients would be the best candidate for each?
Yeah, absolutely. So I think you touched on, we talked about Tezi first initially, and like you said, that is a TSLP. Um, it's a monoclonal antibody, but it blocks TSLP, and it is at the top of the cascade, so it will have a broader impact as the other ones are more downstream. So this one is very unique in that it is so high up compared to the others, and it's more the recent kid on the block, I'd say, since last year. So I do think we'll see how it's going, but it also doesn't have any restrictions on phenotyping. It doesn't have restrictions on how many eosinophils the patient has to have. So I think it is very different, and it is monoclonal antibody that blocks much higher up. So that is one difference to remember with kezepilumab. With dupilumab, that's a fully human IgG4 monoclonal antibody, and this one's amazing because it is against IL-4 and IL-13 because there is a shared receptor where the alpha subunit is shared. So when you block this, you're blocking IL-4 as well as IL-13, and these are major drivers in our type 2 inflammatory processes and disease. So dupilumab is very effective in that way because it is blocking both of those. Omalizumab, which was one of the first, is anti-IgE monoclonal antibody, and this one has more local IgE production in the nasal polyp tissues. And in terms of this one, it is different because it can be dosed every 2 weeks or every 4 weeks based on what it is you're treating. And so this one doesn't have as fixed dosing. So that's the one difference between omalizumab, but it does have local effects in the nasal polyp tissue area. And then mepolizumab is an IL-5 monoclonal antibody, and this one reduces eosinophilic inflammation. And there were many studies that were done, but in the synapse study, it reduced nasal polyp size as well as nasal obstruction, regardless of if they had asthma or AERD or aspirin exacerbated respiratory disease or their eosinophilic count. So all 4 have their own distinct, I guess, style and uniqueness.
Yeah. And I think the age factor is also there, right?
Yes. Yes,
Yeah.
absolutely. So dupilumab is for age 12. We know omalizumab is for age 18, as well as mepolizumab for 18, and I believe Tezi is for age 12 and up.
Yeah, that's great. And I think when we are looking at these patients, as allergists, immunologists, we see mainly type 2 inflammation, but we also see some of those COPD, asthma, crossover type patients. And I think the tezepelumab has really helped us with that to more type 1 inflammatory
Absolutely.
pattern. Yeah.
Or they
So,
don't fit quite in whichever category. And
yeah.
so it has been definitely a great addition to our toolkit.
Tassels, from a surgical standpoint, what are the primary goals of having the endoscopic sinus surgery? Is it just removing the polyps, opening up the sinus outflow tract, or both? And how does this translate into symptom relief, improved response to subsequent medical treatments? And I think you already touched upon it a little bit, but maybe you can tell us a little more about that.
Sure. So as I mentioned earlier, I mean, the intent is to remove the polyps and to allow all the medical treatment that is locally administered to get to the right spots.
Right.
So removing the polyps, the patient gets an immediate effect when it comes to breathing, when it comes to smell, when it comes to the pressure and the sinus complaints that the patient has prior to surgery, the post-nasal drip, all this accumulation of mucus that falls to the back end and causes discomfort. So this is the immediate effect that surgery can offer. Apart from the later effect of opening the areas and cleaning the sinuses and allowing the passages to communicate with the nasal cavities so that whatever is applied locally in the nasal cavity, such as the sprays, the washings, will go to the right spots. Now, that said, it is not as simple as it appears. Why? Because we need also to counsel the patients what is the appropriate administration. We need to show them and to demonstrate how it is the best way to apply the sprays, how do the washings. One. Two, we need also to consider the pros and cons of surgery. So every surgery also has some potential complications. And so when we offer surgery, we need to make sure that we apply modern technology, we apply, high definition cameras, navigation systems that are now widely available that can safely allow us to get into areas very close to the eye sockets or very close to the skull base to prevent complications. Not that this cannot happen. So when we counsel the patients and we take a consent, these are brought down on the table so that the patient will be truly informed of the pros and the cons of this surgery. As much as simple it may sound, it's not a simple surgery. It's a surgery that involves getting close to very important structures. And depending on how also extensive the disease in the sinuses is, then the dangers also increase. So we have to be extremely careful when we apply these surgeries, but at the same time, we need to make the surgery in such a way to open the passages, as I mentioned earlier, for conservative management, local conservative management, local sprays and washings to enter the sinuses and clean them. So this is when it comes. Now, again, as I mentioned earlier, there is also the conservative management that has to be exhausted. There's certain, indications that we need to place. Then again, some patients, it's a patient preference if they want to actually have an immediate effect or wait until conservative management kicks in or, wait for longer because of they are very conservative or because they're afraid of surgeries.
Yeah.
Apart from that,
yeah. Go ahead.
of course, but it's another chapter, like medical problems have that they allow them to safely go through surgery.
Yeah. And I think sometimes it's underestimated how interconnected like the eyeball socket, the sinuses, because I've had patients complain of diplopia and visual problems. And at that point, sending them to our ENT colleagues to find out, is there like reactive new bone formation? How much of the outflow tract is so significantly obstructed that we need our surgical colleagues to help us out? So, so I think there's so much to be considered. It's never it's a case by case basis for sure.
And it's very important, as mentioned, to collaborate because, seeing a CT, for example, or an X-ray that has clouding in the sinuses, this is not a diagnosis. This is just an indication of some inflammatory process going in the sinuses. A diagnosis is placed whenever you have an ENT exam, you do an endoscopy, you look inside the nose, and you see the polyps, rather than assume that any gray thing that you see on an X-ray is a polyp or treats.
Yeah.
So, with different ways. So it's very important to collaborate in that sense.
Yeah, because we have these tiny anterior scopes. That's all we can see, but you guys can actually do the rhinoscopies to see further back. So that really is helpful. So Deepa, so how do the 4 approved biologics compare when you're talking about realistic outcomes for patients, such as like the nasal blockage, their smell, their need for steroids, their need for surgery, and how quickly do these changes happen?
Yeah, no, that's a great question. So there was a 2026 meta-analysis of 13 trials comparing all the 7 biologics, and it's clear that dupilumab and tezepelumab, as well as another one known as stapocabart, if that's how you say it, they are at the top of the line in terms of efficacy, and they don't really show much differences. But prior to that, when you looked at just the 3 before Tezi came on board, dupilumab typically was at the top in terms of all of those scores you just discussed, in terms of quality of life, in the SNOT-22 scores, in the UPSIT scores, as well as smell and nasal symptom scores, and in reduction in corticosteroids. But the Waypoint trial in 25 shows that Tezi has some really great data as well, and we shouldn't, take that out. We just need more time, I guess, looking at all the data for that. We still, since it's kind of new, but definitely dupilumab and Tezi are at the top in terms of all of those scores. In terms of onset of action, dupilumab, typically you'll see some improvement within 2 to 4 weeks, and patients will continue to improve throughout the 52 weeks when you look at the data. And in omalizumab, there was improvement within 4 weeks. And most of these show that, all of these trials show that we really need to continue all of these medications. There really isn't any point where we stop them as of yet. But there needs to be a lot more research in that regard. But you do see symptoms improve significantly. And when you see patients in clinic, they'll tell you within a few doses, they're feeling much better.
Yeah. I actually thought it was pretty impressive with the Waypoint trial, which was published in the New England Journal, that with the tezepelumab, the rate of recurrent surgery reduction was 98%, which was mind-blowing, because I think even with just dupilumab, it's like 16 to 18% or something like that. So we'll have to wait for real world data for sure.
But that is impressive data, and that's exciting, really exciting to have such a big difference.
Yeah, for sure. And then when we're talking about long-term data when it comes to polyp recurrence after surgery, Tassos, especially in patients with the underlying type 2 inflammation, comorbid asthma, how does this inform the decision to add a biologic post-operatively?
Right. That's a very good question. I mean, we know that even, the biologics were initially introduced for lower respiratory tract conditions rather than for nasal polyps. And eventually the benefit was shown trying to hasten the progression of nasal polyps, particularly when someone has had surgery before. Yeah. So having said that, we know again that the guidelines that have been set after multiple, studies and that have been published show that the use of biologics has more value when they are used after surgeries in order to prevent recurrences rather than the first line of treatment. And this is basically the fact that, as we have discussed, has many factors. And the reason is, first of all, the fact that when you clean the bulky polyps, you obviously increase the possibility of the action to be successful with the introduction of a biologic agent after the surgery. One. And two, I believe initially the increased cost of biologic agents was quite the key determinant to avoid using that as a first line of treatment, particularly when there's not any data that this should be done as such. And frankly speaking, being modern medicine that have been introduced for only a few years, we don't have any long-term data about side effects or complications down the line.
Yeah.
We only have the success rate that is actually being posted. These are short-term, as opposed to what we know about antihistamines, as opposed to know about local steroid treatment or systemic steroids that we have been studying for years and years. If we know what to expect with chronic usage, it's something that we don't know. And the patients always wonder, because they see the recurrence and they say, oh, I'm going to go through another surgery. I'm going to go through another surgery. Mm-hmm. Then they say, oh, fantastic. I have a biologic agent that will kill everything. But they don't understand that this may need it to be used for life, because it's not a remedy. It's just another way to stop the progression with different pathways rather than with the knife. So again, this also has to be something that we all counsel the patients. And it's very important to counsel them appropriately and based on what we have as data now. And obviously, with new guidelines and with the long-term follow-ups, we'll be able to know more about the long-term efficacy of these agents. But so far, this is what we have to be honest with our patients and give them what we have in our armamentarium, but also what we know about the things that they can do.
Yeah. And I think specifically with comorbid asthma, it's known to be an independent risk factor for recurrence. And since we have so many great biologics that can help asthmatics in their asthma profile as well, why not? Why not?
Exactly. So these are the primary candidates that actually you two birds with one stone. You improve the asthma that is very refractory to the conventional management with inhalers, and at the same time, you hit another problem that they have, which is the nasal polyps. That's why it's very important, as you mentioned earlier, to do a very thorough workup to find the appropriate candidates and to select the appropriate agent that will be appropriate for the particular patient. Personalized medicine. Absolutely. Same applies for surgical decisions and combined with anything after the surgery or prior to surgery.
Yeah.
Of course, there are the patients that have cardiac problems or anticoagulants, so they have contraindications for surgery. So it's a one way for them, and you have to give them what you believe that can help them, and then wait and see if that's helpful or not.
Yeah, because I've had patients from the get-go, they're like, oh, no, I don't want to do surgery. Or they're older and, they just don't want to go down the surgical path. And we always start with biologics first. And we have fortunately seen some pretty good results, even in my own experience with real and looking now at the real world data, they kind of match up with what we're seeing in our clinics as well. And Deepa, as far as the biologic therapy is considered, when you're thinking of say maintenance treatment, and you had already mentioned for now, all we know is it's going to be indefinite. Do you think there will be scenarios where you can taper patients or discontinue, or does this differ among the 4 biologics?
I think for right now, all of the data shows that you have to continue them indefinitely. When you do discontinue them, like in the Sinus 24 trial with dupilumab, you would see that symptoms do start to come back after week 24. And in other trials like the Sinus 52 trial, you do see that inflammation is reduced throughout. So that shows that ongoing suppression of the type 2 inflammation needs to continue. I'm hoping, this is such a big, biologics are such an advancement that patients don't need prednisone all the time. So I'm hoping one day if we have something better, like Dr. Tasso said, that, for right now, this is what's in our toolkit, and the long-term effects we don't know, but we do know that when you do stop it, you will have inflammation continue. Now, what's really interesting is with omalizumab, when you did stop, a study that was done there after 24 weeks, the patients were actually better than they were before using omalizumab. So there does seem to be some partial durability of response. How long that is, but it is effective just having it on board. So hopefully one day we'll be able to maybe decrease how often they need it. And there are ongoing studies for that right now, but for right now, we need to do that. And then I think with the Waypoint trial, there was also sustained efficacy throughout 52 weeks, which just is another example of suppressing that inflammation is really important for now.
Yeah, so I've had some patients, and it really varies from patient to patient. But if they've already been on it for a good, like say 3-4 months, they're doing great. I do extend the interval. Like instead of 2 weeks, I go to 4 weeks and then 6 weeks. And then you're just trying to get them on the lowest amounts that's required for them. And obviously you don't say that to the insurance company, or they're like, oh, they don't need it anymore.
But I do think you're right there. I've had the same experience, and patients who just do it on their own. Because they want to minimize the medications, and they're doing really well, or those that forgot because they were doing so well. And it does seem to be an example, like with the other studies of 24 weeks. I've had many patients go 6 months and say, oh, I start to feel those polyps come back again. So they start again. So they do their own studies, I guess. They do well.
Yeah, exactly.
So hopefully that'll come. And I've seen some studies where they are working on that. So taking it less may make patients more compliant because they are afraid of the long-term effects.
Yeah. And so far, it's actually been pretty safe as far as
very safe. Very safe.
Yeah. So Tassos, can you walk us through what a realistic recovery timeline and the most important risks patients and referring physicians have to understand? And how does the availability of biologics change your post-op conversation with your patients?
Right. So in terms of what we expect when it's explain patients about the surgical risks, as I mentioned earlier, they have to do with the anatomy of the sinuses and the proximity that it has with certain areas, such as the eye sockets or the orbit is always in danger. The muscles moving the orbit are also in danger. The optic nerve and the carotids, in case that the areas that have been invaded go to the sphenoid sinuses, which is way, way at the back end, that's very close to the skull base. And in the skull base itself, because there are very thin linings of bone separating our sinuses with some certain areas of the skull base. So there may be a risk that the fluid around our brain will fall into the nose, what we call CSF or cerebrospinal fluid, and patients may experience leakage. So it's apart from the common ones, so common one, which is bleeding, which is the pain, the discomfort. In general, operations in the sinus are not painful operations. They just bring some discomfort, some burning sensation, and the pressure from the packing. We have modern packing now that is absorbable. So back in the days when it was started, we're using some spongy packages or some gauzes that were impregnated with Vaseline. So this is the old type of packing. So patients, they're dread, the situation that they would get these things in the nose, so not any longer. This has significantly decreased the post-op discomfort that patients have and the hospital stay, because most of them can be done as day cases, or in the worst case scenario, and 1 day hospital stay. So the discomfort in the nose is much, much less reduced. Pain, as I said, is minimal. And then the activity that needs to be somehow careful physical activity for approximately 1 to 2 weeks, depending on the type of physical activity and also profession that people can be doing. Exposure to sun and heat, particularly in this region, that it's a very hot and humid environment in certain months of the year. So these are the precautions that we give to the patients. Now, in terms of onset of biologics, again, it has to do with the type of surgery that was done. I have many patients that may be coming and they say that, oh, I did surgery, I want to do biologics. And we look at a CT and we see that the surgery that was done was very partial, was very rudimentary. It was not a careful surgery. So not all surgeries are the same, meaning that, we cannot really put everything in the same basket and consider that, oh, if you do one surgery, then the next best thing would be to go and start the biologic agent, because that surgery may be totally complete. So there may be space to do another surgery, prevent a continuous use of an agent that would be unnecessary. But in case that we've seen that the surgery that was done was a very sound surgery, complete, the patient has certain factors that we mentioned earlier of a certain type 2 inflammatory disease and or an asthma. So all these being combined, then with this point we decide that the next thing that should be done would be to start the patient a biologic agent. But it doesn't mean that as even the guidelines actually misinterpret that, because they mentioned that having one or more surgeries, and the quality of the surgery is very different. It's only us that we can look into the nose or look at the CTA, compare and see the type of surgery that was done, if there is space to do something better for that same patient.
Yeah, that's a great point. I mean, I think as a surgeon, I've always remembered you like to read the CT scans yourself, not just what the radiologist is saying. And that is so key because you have that experience to see, oh, what kind of surgery did they do before? Was it a good job or not? I think that's such a great point that you've made. And from the allergist perspective, we don't just use the biologics. For instance, the allergic fungal sinusitis patients with the nasal polyps. Putting them on immunotherapy, allergen immunotherapy, is so crucial because the root cause is the allergy to the fungus that's causing the polyp development. And then we also have our immune deficiency patients who need immunoglobulin treatments. So yeah, when we go back to that precision treatment and understanding why is this person in the first place getting it, I think is so, as like you are talking about with, is this a partially well done surgery or is it not a very well done surgery? For us, it's about why is this polyp coming back over and over again? Biologics may not even be the answer, in that specific scenario. Deepa, for you, what are the most important side effects and barriers, such as cost or definitely insurance approval? Yeah. But for the primary care physician who's treating this patient, what should they be anticipating when they're referring patients for biologics? And what kind of, safety profiles can help differentiate among the four options?
Yeah, absolutely. That's a huge consideration when thinking about biologics. So for your first question, the safety profile is fantastic on all of these medications. For dupilumab, typically it's just in site, like the injection site reaction that patients may experience. And some do get a conjunctivitis of their eyes, typically if they have a history of eczema, but otherwise very, very low issues of side effects. For omalizumab, you'll hear a little bit about headaches. Typically 8 to 9% of patients may complain of that, or nasopharyngitis for omalizumab. There is a risk of anaphylaxis with omalizumab, so there is a black box warning, and you do have to monitor the patient in the clinic initially based on that, because it was one of the first ones. For mepolizumab, also just the nasopharyngitis and some headache is mentioned in the side effect profile, and also with Tezi, it's also the injection site and nasopharyngitis. But for the most part, for all four, headache, nasopharyngitis, and injection site is typically the top three. In terms of cost, so it just depends on where you are. Typically, primary care does need to document what they've tried, how long they've tried it, why it failed, if it failed, what the patient is still complaining about, if they've tried first-line treatment, so that can help the insurance company then help you approve the next step. In systems that some people are in, a lot of times you have to show that they've had previous surgeries or chronic sinus infections that have had required surgeries, and or again, if they've tried intranasal steroids, just documenting is really the largest thing, and if they've seen other specialists and what they think as well. From the allergist standpoint, if they have asthma or eosinophilic esophagitis, also documenting those symptoms as well, so that if you want to, like Dr. Tasso said, using and thinking about the comorbid issues and which biologic would be best for the patient, that'll also set you up for the right one and getting approval down the line.
Yeah, because I can't tell you the number of times I just have a referral, a patient with nasal polyps needs biologic. There's no way that's going to fly with the insurance companies. So absolutely. Yeah. So the more information that's entered by the primary care referring physician and even ENTs, having the CT scan reports showing the bulk of the nasal polyps, all of that also helps our case when we are applying for approvals.
Absolutely. And in my experience, I work with the ENTs on almost all of these patients. We work closely together to decide if, they're going to try the medicals first or they're going to try surgery first. And every time we both write that they're seeing the allergist, they're seeing the ENT, we're working on this together. And a lot of times our approvals will go through because they see that both specialists are working on it.
Yeah, that makes sense. So Tassos, after surgery, and I've been very fortunate to work with you, but just for our audience, can you tell us how do you partner with the allergist, primary care physicians? What ongoing medical therapies, like I know we've already spoken a ton about the biologics, do you think is necessary to prevent recurrence? And how do you choose among, I know you don't mainly choose, but you help the allergist with making that decision. How do you do that?
Well, thank you, Deepa. I mean, we had a very nice collaboration during your presence, and we continue to have nice collaboration with our allergists, colleagues. So in the same way that we have experienced that when we work together, practice has not changed. Every patient that may come comes to us with a problem with nasal polyps, we receive an assessment clinic, including the comprehensive allergy testing, to try to determine if there's any other factors that have led to this. So if there's nothing, then we decide again with the patient on the treatment. If the patient has already been using sprays, antihistamines, or had short course of all steroids without any resolution of the problem, then it's when we decide what would be the next thing. So surgery and biologics. It is something now that we have, as I said, biologics. It's something that we can speak to and discuss with our colleagues whether it would be suitable to start them before surgery or whether we should do surgery and then follow with biologics, given the guidelines and indications. So we collaborate in the same way to make sure that each patient receives the best care and the best possible outcome. The follow-ups are obviously done by both teams. So when a patient is being seen by both physicians, both the allergist and the ENT, even after surgery or even before, we will follow up the patient. Practically, I follow the patient every 3 months until I see that there is a full regression. So for as long as the patient remains on the treatment, we continue to have the follow-up so to ensure that the response is adequate, whether the patient is on biologics or not. Again, we continue to doing this. And if we see that, for example, a patient that has not received biologic treatment, but only surgery, we see the redevelopment of this edematous polypoid degeneration that develops on the linings, particularly in areas that are quite tricky, such as this the front ethmoidal recess and the superior level of the ethmoid sinuses, which is the floor of the skull base that is not well aerated or well reached by the sprays or the local treatment. Is then that we decide to carry on with biologics and to add biologics in the treatment. So in the vast majority, as I said, it's not really the first line of treatment. It is something to consider in failed surgeries, in special cases where surgery is contraindicated, and again, in certain conditions where there is other diseases or comorbidities, such as very severe asthma, that we feel that the patient will have a maximal benefit by combining, these even prior to surgery.
Yeah. So definitely what we've been talking about this whole time, the biologic surgical path is very complementary to each other, and reserving. And even working at Cleveland Clinic, we have so many patients with different insurance support. Some insurances don't care. They're very happy to approve the biologics from the get-go, whereas others are more, it's a sticking point getting the approval. And so I think the conversation and working closely with each other, the interdepartment collaboration, like you were saying, is huge to support our patients and try to do what we can do early on so they don't have to unnecessarily keep struggling to decide which surgery versus biologic kind of thing. And Deepa, in your clinical decision making, when would you prioritize biologic over surgery? And how do you specifically choose the biologic when you see the surgery and biologics are being complementary rather than mutually exclusive?
For the allergy standpoint, if the patient has comorbid conditions and they have eosinophilic esophagitis or atopic dermatitis or urticaria, then dupilumab may be preferred. And also if olfactory improvement, if they really aren't able to smell, then dupilumab would be probably one of our first choices. And if they're requiring a lot of steroids, I think usually we'll go to that. It has so many indications, and so many of our patients have both conditions that they need to do that with. For tezepelumab, I would say if they have severe asthma, and it doesn't look like it's only a type 2 picture, but also a type 1 picture, and it's mixed and they don't have maybe the criteria they need in terms of how many eosinophils or a certain specific phenotype, it's a great option for those patients that don't fit that box that the others may also fix. And also, if you are, on the allergy standpoint, if you are taking care of children as well as adults, there's different age groups. So like we talked about earlier, Tezi and omalizumab are for over 18 versus the dupilumab is younger. And for omalizumab with, food allergies or someone with allergic asthma, those are patients that this would be a great option for too. So you could do two things instead of one and make it more efficient for them.
Yeah, and with omalizumab, with food allergies, it's approved like 6 months. So we can literally even help some of our really young children too if they have those comorbidities. So that's great. So for both of you, I guess Tassos, you can answer this. If you were given one practical algorithm that you can share with your primary care colleagues as to give them guidance or an understanding when they should refer to ENT, when should they refer to allergy, when should they refer to both, and how biologics fits into that pathway, what would that guideline or practical algorithm look like?
I think that, the first thing, as you mentioned, is not just for ENT, but to both, I think would be very useful to refer a patient that has no problems. First of all, for the comprehensive approach in terms of testing, identifying the major key factors that a patient develop polyps, and that's from the allergy immunology side, but then the surgical indications or contraindications from the surgical point. So I think where we should begin is medical treatments on the conservative medical management. That is a traditional one to see how successful it is. If it fails, then we also bind together to see what would be the next step. Depending if the patient has comorbidities or not, then we decide on surgical or conservative management. Patient that has comorbidities that cannot go for surgery, certainly there's a one-way approach, goes directly for biologic agents. So patients that had minimal disease can continue with conservative management. Patient that actually the quality of life, as with a SNOT questionnaire, has been tremendously affected, then we decide with the patient, we discuss and given two options. And as a surgeon, obviously I favor the surgical approach to the beginning and reserve the biologics in case of recurrence, also a recalcitrant disease that has multiple recurrence. So again, trusting previous surgery means that we have to investigate with a CTs to make sure that the surgery that was done before was an optimal surgery rather than just a mini surgery, and decide based on these criteria as well whether we continue or offer another surgery for the patient, or whether again the patient's choices are basically not many, and to continue with one or the other path.
All right. Yeah, that sounds really good. How about you, Deepa?
Yeah, no, I absolutely agree with Dr. Tassos that, if there's, working together, complementing both fields, I think if it looks like there's a surgical need, that's important. If it looks like there's a medical comorbidity, like we said before, you can use those medications to help with that. If you think, it's mild disease, medical management can be tried first. And also, if you think they have AERD or NSAID, exacerbated disease, any of these things that we manage, I think taking that into account is important as well.
Yeah, and knowing some of those alarm symptoms, right?
Yeah.
periorbital swelling, especially the visual changes and everything. Yeah. All right. So thank you both. You've shared a lot of great information with us. And thank you for sharing your experience and helping our listeners, especially our primary care physicians and even the general public. Before we conclude, is there anything else either one of you would like to add?
No, just to thank you for the invitation and for the opportunity to discuss this very important topic. We know that there are many patients suffering from allergies. A lot of them that among these have polyps. A lot of them non-allergic patients have polyps. So it's very important to clarify things, particularly for the audience and primary care physicians, to understand this new concept of the introduction of biologics in armamentarium and to try to see how these are properly approached by both entities, both ENTs and allergists. So again, thank you for the opportunity.
Thank you, Tassos.
Thank you so much. And it was really nice to speak with both of you, and agreed, just shared decision-making is really important to make sure the patient's input is also taken into account, just to make sure they're compliant and see where they are in all of this. But I think it's a really exciting time, and it was really nice to speak with both of you.
Yeah, thank you both again.